everyone, welcome back to the channel. I hope that everybody is doing well today. If you are new here, then hi, my name is Brittany and I am a nurse practitioner, and everything on this channel is either nursing or nurse practitioner education. For today's video, I'm going to be talking all about pediatric asthma, how to diagnose it and how to treat it. But before we get into the video, I did want to tell you a couple of things. If you are not familiar, I am the creator of the Brittany Holzbeck NP Review. I have a total nurse practitioner boards review course available on Patreon. It is currently the most affordable review course on the market, and I've already helped thousands of students pass their licensing exam, so definitely go ahead and check that out. I did just receive accreditation through the AANP as well, so when you complete the course, you can receive continuing education credits. And the really cool thing about that is you don't actually need to be a nurse practitioner student. You could already be a licensed nurse practitioner and take the course and still get the credits, because you know you need those credits to maintain your licensure. And it's just over 17 continuing education credits that you can accumulate, so that's a good handful. I'll go ahead and I'll link everything in the description box below on how to sign up for that boards review. And then also, just recently, I think maybe a month ago, I started another channel here on YouTube that is more my personal account, kind of does some lifestyle things and just allows me to be more creative and venture out from just the educational stuff that I do here on this channel. So if you want to check that out as well, I'll link that channel in the description box below as well. So I would love to have you over there. If you want to come check me out, like I said, everything will be in the description box below. But now let's just get into today's topic of pediatric asthma. All right, so asthma is one of the most common chronic diseases of childhood, and it's estimated in the US alone that over 9 million children have been diagnosed with asthma at some point in their life. So the discussion of how to diagnose and manage pediatric asthma is definitely an important one to have. First, we're going to talk about how these patients present. So the most common presenting symptoms of childhood asthma include coughing and wheezing. Other symptoms, though, include chest tightness and then the feeling of breathlessness. So for the cough, there are a few things that would indicate it's likely attributed to an asthmatic cough versus some other reason for the cough. And so this includes a nocturnal cough. So that's a cough that occurs during the nighttime. And this also can result in fatigue due to poor sleep. A cough that occurs due to specific triggers, so such as cold air, exercise, or if there's an exposure to a specific allergen, and then a cough that persists longer than 3 weeks, especially after recovering from a respiratory infection. All of those are going to be indicators that the cough is attributed to asthma. So an exercise-induced bronchospasm, this occurs in about 90% of children with asthma and occasionally is the only symptom of the child's asthma. So symptoms of their asthma, they typically begin within several minutes of beginning their activity and then will resolve 30 to 60 minutes after stopping the exercise. And so like I said, that occurs in about 90% of children with asthma. So that's definitely an important question to ask when assessing your child, when you're considering asthma as a diagnosis, if they're experiencing these symptoms with exertion and exercise. So wheezing in text, this is described as high-pitched musical sound that occurs from air being pushed through narrow airways. And so as the airway obstruction persists, the wheezing can be heard on both inspiration and expiration. So the more severe the obstruction is, the more wheezing you're going to hear. And if the patient's chest becomes silent, where you are not hearing any wheezing or any audible air movement at all, this is a medical emergency, and that patient needs to be transferred to the emergency room immediately. So on your exam, your assessment of the child is going to oftentimes be normal, of course, unless they're having an exacerbation of their asthma. So a lot of the times, it's going to be really necessary for us to get a really detailed report of symptoms from the child and their primary caregiver for us to be able to make a complete picture of the patient and what's going on with them. If there are abnormal findings on your exam and the patient's not actually having an acute asthma attack or exacerbation, this is likely to indicate that they have much more severe disease, or they're having very poorly controlled asthma, or potentially they're having some other associated atopic conditions like allergic rhinitis. All right, so let's talk now about how we diagnose pediatric asthma. So a history of intermittent or chronic symptoms that are typical of asthma, coupled with auscultation of wheezing on our exam, this is going to be highly indicative of an asthma diagnosis. However, a diagnosis can be confirmed using spirometry. So evidence of an airway obstruction on spirometry, especially if this is reversible with a bronchodilator, this is strongly suggestive of a diagnosis of asthma. However, as mentioned, often on your exam, this is going to be a normal exam unless that patient does have severe disease, or if they're, of course, experiencing an asthma attack or exacerbation. So a trial of asthma medication is going to be appropriate if reported symptoms strongly suggest asthma, or if that patient is unable to perform spirometry. So for example, if they're too young to understand how to accurately perform spirometry, the National Asthma Education and Prevention Program, they recommend performing spirometry in patients 5 years of age and older if a diagnosis of asthma is suspected. In infants and children that are younger than 5 years of age and we suspect asthma, then we can trial asthma medications, and if their symptoms improve or reverse with those medications, then this highly suggests a diagnosis of asthma. So spirometry, this is a very common pulmonary function test, and it measures both the patient's forced vital capacity, or FVC, and their forced expiratory volume in the first second, or the FEV1. So airflow obstruction, this is defined as an FEV1 reduced to less than 80% predicted, and an FEV1 FVC ratio of less than 85%. In the pediatric population, this is a different number for an adult. But for the pediatric population, airflow obstruction is FEV1 reduced to less than 80% predicted, and an FEV1 FVC ratio of less than 85%. Those are really important numbers to remember when taking your board's exam. So spirometry, this should be performed before and after administering a bronchodilator to assess for the reversibility of symptoms. We should do this even if the child has a normal baseline, because oftentimes the child will still experience a response to that bronchodilator and an improvement in their FEV1. So with adults, an increase in the FEV1 of 12% or greater from baseline after administering a short-acting bronchodilator indicates significant reversibility. And we use this number also when establishing a diagnosis of children, so 12% or greater from baseline. However, there are some experts that do recommend a lower number or a lower threshold of only 8% improvement to indicate reversibility of symptoms using a bronchodilator. All right, so let's move on to the treatment. So the main goals of asthma management are going to be to optimize control of the patient's asthma symptoms, reduce their risk of exacerbations, and also minimize their medication side effects. So the 4 components of properly managing a patient's asthma includes pharmacology, patient education, monitoring their lung function, and then finally, but not least important, avoiding asthma triggers. So specifically, exposure to secondhand cigarette smoke is found to be the single most common external risk factor for the development and progression of asthma symptoms in children. And so that's going to be a really important education point as well with our patients and their caregivers, is that these patients, along with all children, but specifically children with asthma, really need to avoid being exposed to secondhand cigarette smoke. All right, so let's look at medications now and what's used in our step up and step down approach when we're managing patients with asthma. So for this, I'm going to be using the Global Initiative for Asthma, or GINA's approach to management. So in children 6 to 11 years old in step 1, so this is when they have symptoms less than 2 times a month, GINA recommends the preferred treatment with a low-dose inhaled corticosteroid whenever the patient is using their short-acting beta agonist, or SABA. Alternatively, you could also have them use a SABA as needed and a daily low-dose inhaled corticosteroid. Step 2, this is classified as patients that have asthma symptoms or the need for their rescue inhaler 2 or more times a month. In this category, Gina recommends the preferred treatment of a daily low-dose inhaled corticosteroid and the use of a SABA PRN or as needed. Step 3 in children 6 to 11 is classified as troublesome asthma symptoms most days, or that they are waking due to their symptoms of asthma one or more times a month. In this step 3, the preferred treatment is going to be a daily low-dose inhaled corticosteroid and a long-acting beta agonist combination inhaler. An alternative treatment would be a daily medium-dose inhaled corticosteroid, and always we're going to have a SABA or short-acting beta agonist as needed on hand. And then step 4 is classified as severe asthma. The preferred treatment for this patient population would be a daily medium-dose inhaled corticosteroid and LABA or long-acting beta agonist combination inhaler, or alternatively, a daily low dose of inhaled corticosteroid plus a leukotriene receptor antagonist with a SABA PRN. And then finally, step 5 is severe asthma that is poorly controlled as well. So the preferred treatment for this population is a daily medium dose inhaled corticosteroid LABA combination inhaler, or even a high dose inhaled corticosteroid LABA combination inhaler. And then of course, again, that SABA inhaler is there as needed. And so when trying to memorize this, it's helpful to remember that the treatment plan in step 1 is only a PRN treatment, so it's only as needed. And step 2 is when we add on our maintenance therapy, which is a daily inhaled corticosteroid. And then step 3 is when we add on our long-acting beta agonist. And then finally, step 4 and step 5 is when we are titrating up on that inhaled corticosteroids. For children 5 years and younger, there is some variation in the management according to Gina. Step 1 is infrequent wheezing with viral infections and little to no symptoms between their illnesses. And treatment for this step is a SABA PRN. Step 2 is asthma symptoms that require SABA treatment 2 or more times a week on average for 1 month, or 3 or more asthma exacerbations per year. And for this class, the preferred treatment is a daily low-dose inhaled corticosteroid plus a SABA PRN. And then step 3 is asthma that's considered not well controlled on a low-dose inhaled corticosteroid. The preferred treatment for this population is a double daily low dose of an inhaled corticosteroid, so in the morning and in the evening, plus a SABA PRN. And then step 4 for children 5 and younger is asthma that is not well controlled on a double daily low-dose inhaled corticosteroid. And preferred treatment for this includes continuing that double daily low-dose inhaled corticosteroid and that SABA PRN, and actually just referring them to an asthma specialist. All right, so as I mentioned, treatment of asthma, it follows a step-up, step-down approach based on how well controlled the patient's asthma is. And so it's really important that we know how do we know a patient's asthma symptoms are well controlled. So symptoms of well-controlled asthma in children between 5 and 11 include asthma symptoms 2 or less days a week, but not more than once in the same day. Nighttime waking due to their symptoms 1 or less times a month. The use of their asthma medication for symptom control 2 or less days a week. The fact that it does not interfere with their daily life and activities. If they have an FEV1 of greater than 80% predicted personal best. If they have an FEV1 FVC ratio of greater than 80%, and if they have 0 up to 1 exacerbations that require oral systemic glucocorticoids per year. That indicates that the child's asthma is well controlled. So symptoms of poorly controlled asthma in children between 5 and 11 would be asthma symptoms greater than 2 days a week or multiple times in the same day on 2 or less days a week. If they have nighttime waking due to their symptoms 2 or more times a month, if they're using their asthma medications for symptom control greater than 2 days a week, if their symptoms are interfering with some of their daily activities, if their FEV1 is of 60 to 80% predicted or their personal best, if their FEV1 FVC ratio is between 75 and 80%, or if they have 2 or more exacerbations a year that requires those oral glucocorticoids again. And so those indicate that the patient is having poorly controlled asthma. And then symptoms of a very poorly controlled patient with asthma in the age range of 5 and 11. So they're having asthma symptoms throughout their day. They're waking up due to their asthma 2 or more times a week. They're using their rescue inhaler several times a day. Their symptoms are significantly interfering with their daily activities. Their FEV1 is less than 60% predicted or personal best, and the FEV1 FVC ratio is less than 75%. Also, they're having 2 or more exacerbations a year that are requiring those oral systemic glucocorticoids. All of those would indicate that the patient has very poorly controlled asthma. And then for children between 0 and 4 years, there are some variations in categorizing the severity of their asthma and whether or not it's well controlled. I'm not actually going to read through this chart, but you can definitely pause the video and look it over. It is relatively similar. However, of course, it's not going to include factoring in the patient's FEV1 or their FEV1 FVC ratio because we're not using spirometry with children less than 5 years. But if you'd like, go ahead and pause it and just kind of review this for your familiarity. All right, and then what is our follow-up plan? So if the child's asthma is defined as well controlled, then it's recommended that we maintain their current regimen and then follow up every 1 to 6 months. You can also consider stepping down their treatment if they are considered well controlled for at least 3 months. If the patient is poorly controlled, then it's recommended to step up their therapy at least 1 step and then reevaluate that patient in 2 to 6 weeks to see if their symptoms are improving. If the patient is very poorly controlled, we should consider a course of those oral systemic glucocorticoids. We should step up their therapy 1 to 2 steps, and we want to reevaluate those patients in 2 weeks. And it's always important that before we step up a patient's therapy, that we first evaluate their adherence to their medication and that they are using their medication, like their inhaler, properly. So very important before we change any of their medication or their dosing. All right, well, I think that's going to complete today's video. Hopefully you learned a little bit. If you enjoyed this video, don't forget to like it and subscribe to the channel. It really helps me out and I really appreciate it. If you have any requests for videos in the upcoming future, go ahead and leave those in the comments below. Otherwise, I wish you guys nothing but the best. Don't forget to learn something new every day, and I'll talk to you soon.